Welcome back. For those of you who are grabbing lunch, please by all means bring your lunch in, relax. We have a wonderful hour ahead of us. For those of you joining us for Stroke 360, this half of the day I guess will be your Stroke 180, but we appreciate your coming late anyways. To start off the keynote, it really is my privilege to introduce Dr. Gregory Albers. Dr. Albers is not only the director of the Stanford Stroke Center, but he co-founded the center in 1992. And the Stanford Stroke Center has been a world leader in stroke research and treatment and pioneered many advancements that we actually take for granted now in stroke therapies throughout the United States. Dr. Albers' primary research focus is diagnosis, management, and prevention of ischemic stroke. And Dr. Albers and his team have used advanced imaging technologies to expand treatment window for ischemic stroke therapy and improving patient health and outcomes as a result. In 2011, Dr. Albers received the American Heart Association's prestigious David G. Sherman Award. That's for the outstanding contribution for stroke research. And for those who aren't familiar with this award, this is really one of the most prestigious awards that a stroke neurologist can receive, a Lifetime Achievement Award for all the work that Dr. Albers had done up to 2011. But it's very inspiring to know that not only did Dr. Albers receive that in 2011, but that since 2011, he's carried out almost another lifetime of research, being without a doubt the leader in imaging-guided approaches to stroke treatment. Specifically, Dr. Albers was instrumental in developing the medical software Rapid. So for all of our residents who take this for granted and have been using it for their entire time here at Methodist, it is an innovation that we're fortunate to have because of the work that he's done. So as a prolific and distinguished researcher, he's authored more than 650 articles on topics related to stroke, and it's my pleasure and privilege to introduce Dr. Greg Albers.
Thank you so much. It's really a pleasure to be here. Sorry not to be in person, but we'll do the best we can. Can you hear me okay?
Yes.
Hopefully the answer is yes, but you can hear me. So I will go right ahead with the talk here. I was asked to talk about what's new with AI, and there's a tremendous amount new with AI. This is a field that is just expanding so rapidly, so hopefully we'll be able to show you some new things and get you up to date a little bit. In terms of disclosures, as already mentioned, the Rapid software we developed at Stanford, it was licensed by IschemaView, and then Genentech, of course, makes both TPA and TNK. So I'm going to start off with a couple of cases. The first one is a 58-year-old woman who has a wake-up stroke, comes in the morning with her NIH of 13. Her non-con CT aspects was read as 8. She has a right MCA occlusion. So let's take a look at a little bit more advanced imaging for her. Here is the mismatch map, where we can see that this patient has quite a large core. I know you had a talk earlier about large core, and people have been more aggressive with the large cores. This one is close to 200 mLs of area that has very low cerebral blood flow. That is this dark pink area, where we have more than a 70% reduction in cerebral blood flow in that area. But if you see there's a large penumbra area, that there's a mismatch volume of close to 100 ml. So non-con CT looks reasonable. Should she be treated? Well, one thing to look a little bit deeper than the mismatch map are the image columns that come out on the software. And here we see something that to us at Stanford is very concerning, that if we look at the cerebral blood volume, there's essentially no blood volume. This very dark blue area means no blood volume going to this very large core region that we already showed had a very low cerebral blood flow. And that's been an area where you really worry about injury to the blood-brain barrier when your blood volume is so low, and it's a little bit like having a cardiac arrest of that big region of the brain where there's essentially no blood flow at all. And in somebody with a cardiac arrest, obviously you only have minutes to be able to reperfuse the brain successfully. So This is one at Stanford we would have been pretty concerned about, but this case was treated with thrombectomy, very successful in terms of recanalization and reperfusion, TICI-3 reperfusion, and after the procedure, the NIH stroke scale was getting a little bit worse, but the non-con CT looked concerning. There was a hope that maybe some of this is contrast from the procedure, but this was a blood clot that expanded, and unfortunately the patient didn't make it. So for this particular large core patient, the thrombectomy didn't look to be a good choice, in retrospect at least. Now here's a case where things were a little bit different. This is somebody even had a much higher NIH stroke scale score of 23, left M1 occlusion. This one is a little bit presumably earlier on. Again, that last one was wake up, so we don't know exactly how far into the stroke the patient was. Here you can see there's also a fairly large core. This is looking rather than at low CBF. If you have an MRI scan, you can look at the core as an area that has severe restriction of the diffusion of water proton molecules. That shows up as this dark pink color. And again, a penumbra on the order of about 100 mLs. So what about the blood flow and blood volume here? Well, you can see that in this case, instead of the terrible collateral situation of the last patient, this patient has very good collaterals, and actually the blood volume is increased. The brain is trying so hard to bring blood into this ischemic region that you actually have an increase in CBV, cerebral blood volume, on these image columns from the software. This patient was treated with thrombectomy, had again a TICI-3 recanalization, and a huge drop in the NIH stroke scale. So from the mid-20s down to 6 at discharge. Obviously the core area was not salvaged, but all the penumbra area, which included the motor strip, was salvaged. So the patient made a very nice recovery and only had some mild hemorrhagic transformation, no hematoma. All right, so this is going to be the introduction to the fact that these images can be helpful in managing patients, and using AI, we can get sophisticated analysis of images, and also through the apps that come with these software packages, you have a tremendous ability to enhance your clinical decision-making in a timely manner, because in the palm of your hand, you can have not only these images, but you can get clinical information that can be brought in from the electronic medical record. You can communicate with your colleagues about the case to try to speed the workflow. You can then communicate back to your colleagues about how well things went during the procedure, and then collect all the data from all your procedures into a big insights database. So a lot of excitement there. And with the new viewers, you're essentially able to do almost everything you can do on a PACS interface right there in the palm of your hand. So you can look at sagittal, coronal, axial images. You can put markers on there to see lesions in different planes. You can point to things and have your colleague see your pointer on their screen. So if you're discussing a case with your interventionalist, you can talk about what vessel is occluded and actually point to it on the screen. You can have the source images. You can pull old images off a PACS work list to compare them. So these multimodality viewers are becoming incredibly powerful and useful, particularly if you're out of the hospital, because while we're taking call outside of the hospital, it's not easy to get to an interface that can connect into the PACS. And here within seconds, you can see the same type of information you get off of PACS. Why is this so helpful? Well, when I'm on call, my life is completely different since the advent of the AI software with the app. In my earlier days, and I started taking stroke call 31 years ago, you couldn't be very far away from a computer. And when you got to that computer to return your page, you had to take a while to log into the PACS system and look at your images. Now, while I'm dialing the ER, I can have all of this information within seconds about what's going on with the patient they're calling me about. So what that means is that my discussion with the ERMD is now very, very focused and very, very quick, which is a great benefit to the ERMD who just wants to know, hey, are you going to take this patient and transfer them or not? And it's a big decision to transfer a patient because it's very expensive. And if it's not a patient where we're going to be able to offer something more at Stanford than they could do at the outside hospital, that's a substantial loss for the patient, for the physicians caring for them locally, and for Stanford, which is very busy, and we want to keep our beds open for patients who can really benefit. So what we were able to publish just last year is that there is a much lower rate of futile transfers if we can actually see the imaging in real time from the outside hospitals, which means that futile transfers are somebody who comes over thinking we're going to be able to do something at the comprehensive center, but we can't because either the stroke is completed or it's not a stroke or it's a tiny little lacoon. So having this imaging data makes a huge difference. So the way my life on call goes is the beeper goes off and it tells me that there's a SIR call. That means somebody they want to transfer for thrombectomy, interventional radiology, from one of our 10 referring hospitals. This one is Community Hospital Monterey, known as CHOMP, and they tell me it's a 69-year-old male they're calling about. So I open the app, I tap on the CHOMP hospital, and instantly I can see this 69-year-old male, and I can see that they have already done a non-con CT, a CTA, and a CT perfusion in Monterey. So I can start tapping through those. I can get to the source images. I can rotate this around, and I see there is no occlusion in the intracranial or extracranial vessels. I can look at the non-con CT window and level it, and notice there's a beautifully normal non-con CT for this patient with stroke-like symptoms. And then most important to us is the perfusion imaging, and our 10 most common referral sites are all doing perfusion imaging, so that makes it very easy to see that the blood flow, the blood volume, the transit times are all normal. And quickly I realized that this patient is not having a stroke, and this can focus the question to the ER doc about stroke mimics. Is this a seizure? Is it a migraine? Turned out to be a complicated migraine in this patient. Obviously, we do not need to transfer the patient from Monterey to Stanford. But a few minutes later, we get another call. This one is from Dominican Hospital in Santa Cruz. And here you immediately see it's a different story. We get notified that there's a suspected LVO. This already flashed on my screen before the call from the ER came in, because immediately when the scan is done, we get the notification there's a suspected LVO. We can see that there's a substantial reduction in blood vessel density in that left hemisphere, and then we can go through the source images to see exactly where this was, which was a very proximal M2. We can also see on perfusion a note that thrombectomy may be indicated. We can see that how much mismatch is available, and then we can get something that we find very helpful, which is this collateral map, which shows us how severe the delay in the arrival of the contrast material into the penumbra is. And this is measured by something called an HIR, which is telling you what percentage of the penumbra is red, and red means there's more than a 10-second delay for the contrast material to get into that penumbra. And that long delay tells us the patient has poor collaterals. And there have been a whole series of articles, some of the very big ones have come out just within the last year, showing that this HIR, in other words, what percent of the penumbra has a severe restriction in collateral flow, can tell us whether that patient is a fast progressor or a slow progressor. And a fast progressor is somebody where that infarct is growing by more than 10 mLs per hour, and a slow progressor is somebody where the infarct is really not progressing at all, which is not uncommon, that the infarct core can stay stable for several hours, and then as the collaterals fail, it takes off. So here we can see for the HIR that our patient had, there's an 80% chance that that patient is a fast progressor. So it gives us an idea that that infarct core is going to be a bit bigger by the time they get from Santa Cruz to Stanford. All right, so let's now take a deeper dive into the benefits and limitations of AI and talk about the explosion of AI software, all the different modalities modules that are now available for AI. And as you look at any news outlet these days, you're likely to see some article that says AI has done some amazing thing and it's great, and then you're just as equally likely to see some article that says AI is dangerous and it's going to be the end of civilization. So we're going to talk about pros and cons of AI software in the setting of evaluating stroke patients. So one of the things that's important to know is that no AI is perfect, and I'm always surprised when somebody is very disappointed when they find out that there's a false positive or a false negative, because they have the idea that if this is done by a fancy computer, it shouldn't make mistakes. That the computer makes mistakes just like humans make mistakes, and it's really working together, that it's always got to be the clinician and the AI working together, because sometimes the AI is going to get fooled by some artifact that the clinician can pick up, and sometimes the clinician is going to miss something subtle that the AI picks up. So you're going to do much better if you work together rather than assuming the software is correct. The other thing that's really important as imaging protocols are evolving so quickly is that the software needs to be trained on the protocols that are used at your site. So if you're moving on to new fancy protocols and the software wasn't trained for that, you may not get the performance that you're expecting. And I'll give some examples of that during the talk. Technical issues are obviously important. If you've got crappy images going into the software, you're not going to get a sophisticated output. So having the appropriate bolus timing, have the patient hold still, and then technical things like the slice thickness and the field of view are also very important. All right, so here is the modules that are currently cleared for stroke patients. So the good news is I will not be walking through all of these modules. I'll just be giving you some highlights about what's new and what's evolving as we look at evaluating ischemic stroke, brain hemorrhages, and aneurysms, and how can AI software help us. Well, there have been a lot of innovation. So if you're familiar with the software from 3 years ago, it's probably out of date these days. The softwares have to evolve into new versions because the technology is improving, the protocols are changing, and we're learning a lot from software that was out 3 years ago. Where were the false positives and where were the false negative cases? And can we show the computer how not to make those mistakes? And the answer is yes, and that's leading to much higher sensitivity and specificity with the newer updates to some of these older AI programs. The AI software now can measure complex volumes. You can imagine if you asked a radiologist to try to measure the volume of this intraparenchymal and intraventricular hemorrhage, that they would not be able to do it very accurately, or to do it accurately would take a long time to circle every one of these lesions and add up the volumes. This can be done in less than a minute with AI software. What if you want to know if there's a large vessel occlusion from just a basic non-con CT? I'll show you that that is now possible with AI. If you want to detect hard-to-find lesions, like an aneurysm that can be easily missed, these days we do so many CTAs because we're looking to do thrombectomies, but sometimes when we find the occluded MCA, we forgot to take a close look at the PCOM and we might miss a smaller aneurysm. And then if you need a fast and accurate linear measurement, like an asset score, you want to know the RV-LV ratio in somebody who's just had a PE, these things can come out very quickly and automatically with software. All right, so let's talk about brain hemorrhage detectors. The most common FDA clearance for a stroke software is brain hemorrhage detection. There's actually courses given at radiology meetings on how you can develop this yourself, right? It's not rocket science. You basically have to circle, a few hundred brain hemorrhages and feed that into a neural network, and then the network can learn to recognize the hemorrhages. The early versions that came out a few years ago, one of the biggest complaints were the false positives, because these are triage and notification softwares, at least the initial ones were. And triage and notification means that all the software can do is say, I suspect a hemorrhage, but it can't tell you where it is. Here it's pretty obvious because we can see it on the screen, but what if you get the notice that there's a suspected hemorrhage and you look all over and you can't find it? Is that because you're not good at finding the hemorrhage, or is it because this is a false positive? And it was about a 5% false positive rates for the early versions of the hemorrhage detection software. So figuring out what was causing the false positives and feeding that back into the AI engineers has led to major improvements. So this is the rapid ICH3 paper published just recently, showing that we are now up to a specificity of 99.5. Out of this 881 patients, there were only 2 false positives. So basically, when you get the message suspected hemorrhage, you can be 99.5% sure there is a hemorrhage to be found, and probably you shouldn't push your TPA or TNK if you get this message. The sensitivity has remained incredibly high for all types of intracranial hemorrhages, and they are picking up hemorrhages now as small as 0.4 mLs with 1 minute of processing time. So this is a huge advantage. The other comment that came back from the ICH 1.0 version is, hey, I need the volume. And the FDA has been challenging about approving AI-based volumes, but this hyperdensity module has been on the market now for about a year, which is a sophisticated way to measure ICH volumes. What this software does is it identifies the normal hyperdense structures in the brain, calcium choroid plexus, calcified falx, etc. It suppresses that and shows you the volume of any pathologic hyperdensity in the brain, which could be a hyperdense tumor, but 98% of the time, it's a brain hemorrhage. And it's going to give you a very accurate measurement that matches hand-drawn volumes by expert neuroradiologists with an incredibly high Pearson correlation. This was an abstract that we had at the ISC last year. So this can help you if you want to know, is the hemorrhage stable? If you want to decide if a small hemorrhage doesn't need to be transferred from an outside hospital, if you want to know, does the volume meet the requirement for one of the new surgical procedures to remove subcortical hemorrhages, or if you're doing comprehensive stroke center accreditation and you have to fill out for all your hemorrhage patients, is this over 30 or under 30? The nurses who are working on those can just take a look, because oftentimes the radiology report doesn't tell you that this is a 51 ml hemorrhage. So this can be quite useful. Subdurals may have a very big year this year, because slated for the ISC in Phoenix in just a month from now, we're going to start seeing the results of these middle meningeal artery embolization studies coming out. And these are studies where you have patients who have chronic subdurals, right? They've had the acute subdural that's been treated, but then a membrane forms, which is leaking CSF into the subdural space. So you wind up getting a dark area of CSF in the subdural area, and these can be quite disabling in elderly patients. They're quite common as the baby boomers get into the subdural hemorrhage high-risk age group. So these can now be identified, their max wish can be measured, and these patients can then be treated, assuming that the studies come out as positive as many people are predicting, with this middle meningeal embolization procedure that cuts off the blood flow to the membrane that is causing this chronic leak. So many surgeons think this is going to become one of the most common neurosurgical procedures over the next decade. So it's nice to be able to identify these and inform you when you've got somebody who's got a chronic subdural hemorrhage. Okay, we're going to talk now about, excuse me, a breakthrough designation that the FDA has given to certain AI software. As you see all of these different modules that I'm talking about, you can imagine that if a patient gets some scans and all of a sudden your phone goes off with 10 different notifications, giving you 10 different pieces of information about that patient, it may be a little overwhelming, particularly if half of them don't even relate to your patient. So the breakthrough designation that we've been working on the FDA with is to allow multiple modules to work together. so that if it's a brain hemorrhage patient, you're going to get information relative to the brain hemorrhage. What's the width of subdural? Is there a midline shift? What's the volume of that hemorrhage? But if it's not, you're going to get information related to ischemic stroke patient. Where is the occlusion? What's the aspect score? Is there a LVO based on a non-con CT? So this product, which is called Rapid NCCT, which just came out very recently in this nice paper published in Frontier Neurology in November, just a couple months ago, shows how this can work. And you can imagine how this can move many steps further. But for this product, there are 3 modules at play. First module is the ICH3 module that I showed you, which is going to say, is there a brain hemorrhage, yes or no? If there is a brain hemorrhage, then you don't move on to the ischemic stroke modules. If there's not, you're going to move on to look for a hyperdense MCA sign, and that is going to allow you to pick up about 40% of LVOs from a non-con CT, but to pick up another 20-25%, you're going to look for subtle early ischemic changes within the MCA territory on that non-con CT. And using the combination of those 2 ischemic stroke modules, the software was able to pick up 64% of the LVOs with a non-con CT alone. The radiologist picked up 41%. So this was a big difference of more than 20% additional yield. And this is something where you'll get a notification immediately as the non-con CT is completed. And somebody will say, well, look, I'm going to find out immediately if I've got an LVO because I always do a CTA immediately after the non-con. Well, we did a big survey of the country, which is going to be presented at Phoenix next month, and showed that about 25% of the hospitals for LVO patients, the strategy was get a non-con, take the patient off, talk to somebody about the non-con, and then go back for the CTA. And that can lead to a substantial delay in figuring out there's an LVO. We have a couple of our referral sites in the Bay Area that do that strategy. We get a call at Stanford. The patient's been there for an hour and a half, sometimes even 2 hours in the ER before they picked up they have an LVO that needs immediate transfers for thrombectomy. So a hospital like that could benefit for this, and places like Brazil are really excited because the thrombectomy centers say, a lot of my sites don't even do CTAs. I have no idea who to transfer in. So here you could at least capture about 2/3 of your LVOs and transfer them in. All right, obviously the standard way to detect an LVO is to do a CTA. And if you're doing a CTA, then AI can be helpful. One, it can give you a notification that there's an LVO. And 2, it can look at the vessel density throughout the hemisphere. And because of that, it can pick up smaller vessel lesions. Maybe you've got an M2 or an M3 occlusion, and you can see that there's a mild, in the blue or green level of reduction in vessel density. The other thing that you can get out of AI is these immediate 3D vascular reconstructions. You can get these MIPs that make it way easier to read a CTA than going through source images. So that can be helpful. All right, I promised to talk about some limitations. So let's talk about some situation where the CTA software can make a mistake. Well, as I said, these softwares are trained for specific protocols. In other words, there's a specific field of view that you need to be using that matches how the software was designed. Here's a case where the field of view did not match with the specifications of the software, and this case gets a notification that there's an LVO, and in reality, there is no LVO in this case. So here, if you scan the patient with the recommended field of view, you can see no problem here versus this false positive with the mismatched field of view. All right, let's talk about Aspects. Aspects software has been on the market for a few years, both in Europe and the US. It allows you to see an aspect score, and people are pretty interested in this now that we've got these large core trials saying that you can treat some lower aspect scores. So here's from back in radiology in 2019. This was an interesting study from a couple of neuroradiologists who said, hey, I don't think this software can possibly be good as a radiologist. So they did a study where they compared their aspects reading before thrombectomy with the software. And the gold standard was after they had a successful thrombectomy and they had a final infarct volume, they went ahead and redid the aspects, blinded to their initial aspects. So they have the final infarct, they have the baseline non-con, so they say, do I see subtle changes in the areas that went on to infarct? That was their gold standard. And although their hypothesis was that the human was better than the software, they published in Radiology that the software actually had a much better correlation with the gold standard than the human. So sometimes the software can pick up things that are more subtle that the human doesn't. But sometimes there can be problems. So here's an example from the University of Wisconsin. This is a site, very sophisticated a neuroradiology site led by Howard Rowley for many years that does protocol development for GE. So they're often testing new protocols. And they were using the Aspects software, and they gave us a call and said, this Aspects software seems to be a random number generator. It's not working. So obviously you take that very seriously, and they sent a whole bunch of cases, and we could easily see that the results were not correct. This was a good-looking scan that's getting a low aspect score. So what was going on? Well, if the software is not performing, you need to take a look. The first thing that we look at is what protocol is being used. And what they were doing was a new protocol where they took thick overlapping slabs. They were trying to get higher resolution by thick overlapping slabs. And when you take that thick overlapping slab and you tilt correct it, and to get a good aspect score, you have to tilt correct, right? So when you tilt correct it, you can get false positive regions. So the solution was to take thin slabs, rerun the cases through thin slabs rather than these thick slabs, and then you can see this false positive of a 6 now becomes a normal aspect score of 10. So again, the lesson is if the software doesn't seem to be performing as advertised, contact the company, take a look at the protocols, and it is really helpful to mark cases that don't seem right so that the new versions can improve. All right, what are some of the limitations of aspects? Well, I think we're going to be seeing more and more of this as we try to look at the role of aspects in these large core studies. One of the things that may have been discussed earlier today was the Angel Aspects study, which published a sub-study just recently in JAMA Neurology, where they showed that an aspects 3 to 5 with a large core on CT perfusion had a different response, not nearly as good a response as an aspects 3 to 5 with a smaller core on CT perfusion. We've seen the same with the SELECT-2 data, and there'll be data coming out on this over the next few months as well. So aspects has a couple of limitations. One, it really doesn't give you the volume, because you could have that low aspect score because of a lot of high volume regions, or you could have a lot of low volume regions like the insula, internal capsule, caudate contributing. So AI can give you actually the volume of the hypodensity, and the other thing is the severity is not part of the aspect score. So in these large core trials, there was a lot of disagreement between core labs and investigators, because when you're looking at a subtle change, not everybody, including neuroradiologists, will agree how far does that subtle change go. Whereas if you have a more severe hypodensity, it becomes more obvious. So here's a hypodensity volume module that can tell you not only what's the volume, but the severity. So we can look at 9 to 12 Hounsfield units of change in dark blue, and there's going to be a presentation by Bruce Campbell from the SELECT data showing that probably the severity of the hypodensity may be very important in predicting which large core patients are going to have the most benefit from thrombectomy. So being able to know not just an aspect score, but what's the volume of hypodensity and what's the severity, I think is going to become an important issue over the next few years. All right, let's switch gears to something different. How about aneurysms? As I mentioned earlier, it's a little bit frightening to see how many aneurysms are missed, and radiologists are being pushed these days to read scans faster and faster. You have many radiologists reading CTAs that are not neuroradiologists, and aneurysms can be tough to tell from infundibulums and other little bumps on vessels. So it's nice to have some software that can have good sensitivity and specificity for picking up aneurysms. And as I'll show you, the unique measurements that AI software can make of an aneurysm can make a huge difference. A lot of radiologists will give you a linear measurement, a max diameter, neck width, but I'm going to show you that surface area and volume can make a huge deal when you're trying to follow an aneurysm and determine, is that aneurysm growing or is it stable? So this was a study that really brought that to light. This is just a little over a year ago in JNIS, where this group from the Ascension Hospitals, led by Dan Saline, did something somewhat brave, which was to go through their database and find the disastrous situations that everybody fears, which is that you tell somebody that their aneurysm is stable and they don't need to worry about it, and despite that, they come back before their next image with a subarachnoid hemorrhage. So they found that that happened in their large database 5 times. And they wanted to know, for these 5 cases, if they had had the AI software, would the software have said something different than the radiologist? So here's how it worked. Here is one of these cases where they have the baseline. This is aneurysm that's detected for the first time on the scan. The patient is told to come back at 6 months and have another scan. Here at 7 months, they came back, and everybody looked at it, standard imaging, good quality CTA, and they said, it's stable. Don't worry about it. Good news. We'll see you in a year for another follow-up. Patient didn't make it a year. They had a subarachnoid hemorrhage. So they went back and fed these 2 scans through the AI software, as is the rapid aneurysm software, and you can see that the surface area and volume are measured here. The aneurysm is co-registered. The follow-up is slapped right on top of the baseline, and it's very clear that this aneurysm was not stable. This aneurysm was growing. It wasn't growing a lot, but it was called positive by the software. And it turned out for all 5 of the cases that they had found that were thought to have this situation, the software identified that the growth had occurred. So that's what led them to say in this very provocative paper that we may be following aneurysms wrong. These linear measurements have got error. They are not as reliable as something that would be done by software and includes surface area and volume. So the possibility that a number of aneurysms that are growing are being missed, and that if these patients are identified, it's going to lead to procedures that could potentially prevent some subarachnoid hemorrhages. All right, how about something else on the horizon? You have a patient who's at an outside hospital. They look like a great candidate for thrombectomy. You transfer them to your hospital, and you typically want to go straight into the cath lab. Well, what if things happen during the trip? What if they got TNK at the outside hospital and now they've recanalized? What if their collaterals were bad, they had a high HIR, and they went on to infarct a huge territory? Well, you could find out about this by doing what's called the cone beam CT perfusion. This is one revolution of the C-arm of the angiography machine, and the signal to noise is not quite as beautiful as a standard CTP, but it's darn close. So here's an example from a paper published in Stroke where we had the standard CTP in the ER, then you did the cone beam on arrival to the angio suite, and you can see here, here's the images from standard CTP, here's the images from the quick and dirty cone beam CTP. They really give you a good idea what's going on. You can certainly see the vascular territory involved, get an idea what region has very low CBF. Here was a European study that did the same thing, showing again a nice match between CTP in the ER and the cone beam CT perfusion. So I think over the next several years we're going to see more and more direct to angio, and it's helpful to be able to get this information quickly before you do the procedure, because if the patient's recanalized, they don't need a femoral stick and angiography. And then what's exciting is the idea that even after the procedure, that some patients who look like they're, a great TICI 2B or 3 result still may have a substantial area of Tmax delay. And a nice study from Mark Rebo in Barcelona showed that patients who have persistent Tmax delays after what seems to be a successful thrombectomy, they have a worse prognosis. So this would give you a chance to do something in the cath lab, maybe intra-arterial thrombolytic, to try to really clean up all the perfusion deficit before you send the patient out of the angio suite. So I think this is exciting for the future. The other thing that we're very excited about is this new module that gives you the same information that you get from your 3D lab in real time. So even at Stanford, we're doing a thrombectomy in the evening or at night. We don't get these beautiful 3D lab pictures until the next morning. So if we want to see these curved planar images, or if we want to be able to really look, what's my best approach, radial or femoral, or what's the highway look like on the way up to my clot, we're stuck at looking through the source images. So having this Neuro 3D module that can give you these vessels in real time, we think is going to be a huge benefit as you're going and planning these emergency thrombectomy procedures in the night and the weekend. So to summarize, I think there's a tremendous amount of promise with AI. I've tried to show you some of the really exciting things that have been breaking over the last year and will continue to come out over the next few years to help make our lives easier, but also want to, again, reinforce the idea that no AI is perfect. There's always going to be false positives and false negatives and problems with protocols, so it is really critical that the clinician oversee this. And the work that we've done, we never had the idea that we're trying to replace any clinician. We're trying to make us more efficient, make our lives easier, and make us more accurate. So it's really the partnership between the AI and the physician that's going to lead to better patient care. Thank you very much.
Thank you, Dr. Albers. We'll open it for questions, and I'll just ask anyone to please come to the microphones because I think that's the only way you'll hear us. First question I have is, when we're called, sometimes that patient who has like a dense gaze preference and you're very concerned this is an elvo, and then everything is negative, you wonder whether this is a seizure. And if there's anything on the horizon that might be, imaging detection of a seizure phenotype from the software.
Yeah, that's absolutely a fantastic question. We actually had one patient who got enrolled in the Timeless study who had a seizure rather than a stroke. And if you look at the CT perfusion from that case, what you'll see is kind of the opposite of the stroke in many of these patients, particularly if you catch them during the seizure. So what you're going to see is an increase in CBF and CBV rather than the typical decrease that you usually see in acute stroke. And you'll often see this along the cortical margin. So rather than being, the wedge-shaped pattern that you're going to get with an MCA occlusion, you're going to see the cortex light up. So in that patient, you could see the occipital lobe cortex light up, and it just goes right into the parietal lobe. So it's a non-vascular distribution of hyperintensity. So it's an increase in CBF rather than a decrease. So it depends on the phase of the seizure, but if they're actively seizing, you expect to see an increase in CBF and CBV. It also brings up the question about stroke mimics, which I'm sure we all see these. That somebody comes in, they're not speaking, right? They're not responding, they're not speaking. The residents are rushing in with the TNK or TPA ready to treat this MCA stroke, and then you do the CT. And the way our CTs go, we do non-con, CT perfusion, and then CTA. So by the time the patient is done with their CTA, we've already got the CT perfusion on our phone. And if you see that the blood flow in the hemisphere is completely normal, this is not somebody who's got an aphasia from a stroke, right? This is a stroke mimic, which is often a migraine or seizure, or sometimes they're just not in the mood to speak that day, right? We get a lot of functional patients. And it also works the other way, that we have a low threshold at Stanford for doing CT perfusion. So people who have atypical stroke presentations, right? Some of these right parietal strokes that present more with confusion and you think it's an elderly patient with a UTI or something, turns out to be a stroke. We've had cases where the ER is, ready to call ophthalmology because they think it's an eye problem and it's a PCA occlusion, or they just have a weak leg and they're not suspecting a stroke, it's an ACA occlusion. So we're pretty liberal with doing the CT perfusion, and we find it incredibly helpful for even, sorting out who does or doesn't need TPA.
Yeah, thank you. Equally, we've had the same observations that CTP is very helpful for some of the cases, the margins especially. The other question, I think, getting a little bit broader in AI, that there have been so many, you mentioned so many AI tools, and they're out there. The struggle is implementation and making something work in the workflow of healthcare, which is its own kind of complex system with different stakeholders. And any lessons learned about the rapid experience and how you all were able to integrate into workflows and how you manage that change?
Yeah, well, it's still a work in progress, right? This is all new. And that's why I was emphasizing this breakthrough designation that we've been able to get through the FDA, which is, we have a ton of modules out there, and a lot of them just don't relate to a given patient, right? You don't want to get a midline shift read on somebody who doesn't have a mass lesion in their brain, right? Because the brain is asymmetric, and often we have tiny midline shifts that's part of normal. So we want to tailor that to get a midline shift when you actually have a lesion. Or if you have a chronic subdural, you want the maximum width, right? You don't want a maximum width of some other lesion, right? So the idea is to get the software to talk to each other. So by moving on to cloud processing, we can do parallel processing of these modules, and then the modules can talk to each other, right? For example, you don't need an aspect score if you've got a brain hemorrhage. That's not going to be helpful. So that's a lot of that type of integration. And then it's getting out to the hospitals and trying to customize to your workflow, right? To figure out which modules are going to be most useful for the workflow at your hospital. And so we have a team that goes out and tries to do that, and then making sure that everybody knows how to use the app. There's a lot of features on the app that people don't know. So it's a bit of an effort to train people to say, this is how you can use the app most effectively. And also the app keeps changing, right? There's all these new innovations. So it's updating to new versions, and so it is a bit of a challenge to get the education out there, to show people how they can use this most efficiently. At Stanford, when we have a call for a thrombectomy, we have 3 people on the line. We have the interventionalist who's going to do the procedure, our stroke fellow, and the stroke attending. And it is incredibly helpful to have everybody on that app looking at the same thing, making the decision, is this patient somebody who the interventionalist feels comfortable with, right? So that we can really just transfer over the patients that we need, that we can help at Stanford, rather than somebody who we're not going to do anything different.
Thank you. Well, I think we're at the bottom of the hour, so thank you very much. Thank you for your dedication to education and the science, and it's been such an inspiration to hear this journey and the continued innovation, so we really appreciate it, and thank you so much.
Thanks for inviting me. Appreciate it. Take care, everybody.